Very good evening, everyone. Myself, Dr. Nikhil Gupta, today's speaker. और आज का हमारा टॉपिक रहेगा हाउ टू ओपीडी में क्लिनिकली रिलेट क्लिनिकल एग्जामिनेशन एंड रेडियोलॉजी इन द केस ऑफ लंबार बैक पेन और कटी शूला. एज वी नो, सही डायग्नोसिस के लिए दोनों का बैलेंस समझना बहुत ही जरूरी है. सो लेट्स बिगिन टुडे. And if any queries any queries, it can be posted in the chat box, and request everyone to stay on mute to avoid disturbances. So here I'll be sharing my screen now, and the session will be recorded. A very good evening, everyone. Today we have Dr. Mahesh Sanghvi sir with us.
थैंक यू वेरी मच निखिल. आज की जो चर्चा विचारना हम करेंगे और शेयरिंग द नॉलेज जो है वो आपको याद रखनी चाहिए और उसको जो है क्लिनिकल प्रैक्टिस में रखना चाहिए, क्योंकि मेरा ऐसा व्यक्तिगत रूप से मानना है कि यदि आप लोग इसमें ध्यान नहीं देंगे, ट्रीटमेंट हो जाएगी, सब कुछ हो जाएगा, आपको सेटिस्फेक्शन नहीं होगा. और दूसरा ये है कि आप मनचाहा रिजल्ट नहीं मिलेगा, क्योंकि ये नया नया है. इसके लिए आपको अच्छा लगेगा और अच्छा ही है, आप लोग अच्छा करते भी होंगे, लेकिन हमारा ये प्रयत्न है कि बेसिक नॉलेज के साथ भी यदि हम करेंगे तो अच्छा होगा. निखिल ने आज बहुत अच्छी तरह से तैयारी की है. माँ शारदा और सुश्रुत महाराज इनको शक्ति दे और वो आपसे अपना विचार विमर्श करेंगे. डॉक्टर निखिल गुप्ता, MS आयुर्वेद.
Thank you so much, sir. So I pray my blessings to Lord Dhanvantari, Ma Saraswati, and Acharya Sushruta for giving us the knowledge of Ayurveda. Om Dhanvantaraya Namaha. Before starting my presentation, I would also like to thank my parents, my teachers, my mentor, my guru, and my colleagues and dear juniors for giving their constant support. So our topic is Kati Shoola, none other than lumbar back pain. So today we'll be discussing, focusing on clinical examination and radiology. So this is the title slide where we'll see the inspection, palpation, range of motion, neurological examination, क्या special test करते हैं ओपीडी में जानने के लिए, एंड द फंक्शनल टेस्ट क्या क्या होते हैं. So first, starting with the inspection, what will you inspect? See, here we have a picture of two spines, and if we appreciate the curvatures, जो healthy spine है at the left side of your picture, the curvature is absolutely normal. But जो right side का image है, यहाँ पे we can see the pathological curvature. The curvature is too deep. तो normal क्या होता है? Let's see. So in the picture, the first thing we need to see, there is a cervical lordosis. This is a normal spine. Followed by thoracic region में there is a kyphosis. And again lumbar region में a slight lordosis can be seen. So this is a curvature which every clinician should know in their OPD. This is a normal spine. What is a scoliosis? Scoliosis मतलब the shape. There is a S-shaped curve of a spine. As you can appreciate in the image, the shape of a spine is in S shape and there is a lateral curvature. Whereas in the kyphosis, if we see, बहुत सारे आजकल की यंग जनरेशन के जो स्पाइन कर्वेचर रहते हैं वो exaggerated thoracic curve रहते हैं. It is a shape of kyphosis. And last is the lordosis. यहाँ पे जो curvature है of lumbar region that gets too much exaggerated, and ऐसे patients में we'll see the exaggerated lumbar curve. So this is a clinical examination, how you inspect a patient when he comes to your OPD. how he walks. It is very important. If you see the video of this boy, so this boy is a 16-year-old male who had been prescribed a injection at the gluteal region by some local sister. And after that, he was suffering from a muscular spasm, a muscular pain, and he was unable to walk, unable to sit, unable to do his normal functions. So ये बहुत ही निहायत जरूरी है अपने क्लिनिक में देखना कि पेशेंट कैसे आता है, क्या तकलीफ लेके आता है, कितने तकलीफ में है. A proper clinical examination will give you a thorough diagnosis, and a thorough diagnosis will give you a successful treatment. तो एग्जामिनेशन में वी सी टू थिंग्स. एक तो हमारा पेशेंट का कर्वेचर, एंड सेकेंड थिंग उसका गेट, which type of gait it is, high stepping gait, antalgic gait, what gait he is coming with you. Second thing is palpation. Can you appreciate this hand? The hand is kept on the erector spinae muscles. It is kept on the multifidus muscles. It is kept on the facet joint. यहाँ पे स्पाइनस प्रोसेस को इंस्पेक्शन करते. यू नीड टू फील ईच एंड एवरीथिंग इन द ओपीडी. कहाँ पे पेन है? As in our previous session, we had discussed about the OPD, about the anatomy, which all muscles were there. Next, can you appreciate this hand? He's checking the posterior superior iliac spine, the iliac crest. And this hand is very important as it is palpating the sacral region और sacroiliac region. ये वाला पोर्शन जो होता है वो उसको कहते हैं sacroiliac region. तो कहाँ पे टेंडरनेस है, कहाँ पे palpation, कहाँ पे पेन है, इट इज वेरी इंपॉर्टेंट टू नो. See, when it comes to palpation in the OPD, we need to remember only these things, which I'm going to focus. एक है spinous process, एक है sacrum, एक है posterior superior and anterior superior iliac spine. Next is the iliac crest, and last is the sacroiliac joint. ये सब चीज OPD में we will palpate. These are the most important findings. So next is हमको पेशेंट का रेंज ऑफ मोशन का एग्जामिन करना. इट इज वेरी इंपॉर्टेंट. हाउ मच अ पेशेंट कैन फ्लेक्स, बेंड फॉरवर्ड्स, हाउ मच ही कैन एक्सटेंड बैकवर्ड्स, लैटरली वो कितना फ्लेक्स कर सकता है. इट इज वेरी इंपॉर्टेंट टू नो द स्टिफनेस. वी नीड टू नो द रोटेशन, हाउ मच अ पेशेंट कैन रोटेट हिज स्पाइन, whether it is a stiff spine, whether there is any pathology, radiating pain, numbness, what it is. We need to know that things. ये है Scober's test. We'll discuss this in detail. So basically, Scober. So for Scober's test, we can see first we'll go with the right image. Right side में जो image है, we can see two crosses. Can you appreciate this two crosses? Yes. So these are 2 points. These points are called as posterior superior iliac spine. यहाँ पे क्या होता है कि there is a mark done at the posterior superior iliac spine. Just 10 centimeter above this cross, we have to make another cross. We have to make another cross, and when the patient is standing in the erect position, we'll mark that cross. Then we can appreciate in this image, the patient is asked to bend forward, and then the measure is done between the two crosses. I will show you practically in the next slide. क्या होता है? So on standing, as we measured, it was 10 centimeter, right? When the patient was asked to flex completely and his fingers are touching to the toes, the same distance between the two crosses were 17 centimeter. There was a change of 7 centimeter. So this shows that the spine is very healthy. अगर ये distance में अगर वो 5 centimeter से less रहा, as we know in the pathology, it is said over here, the normal is greater than 5 centimeter का change दिखे, it is absolutely normal. But if in your OPD 5 centimeter से कम change दिखता है, so we can diagnose that patient as, or we may suspect, not diagnose, we may suspect this patient with ankylosing spondylitis. So this is a video of a patient. A cross mark was done at the posterior superior iliac spine. And another cross after. Another cross was done and it was measured. So as on the right hand side, we can see the image. A cross here at the tip of a pen. Another cross is at the mid of the pen. But when we asked the patient to flex, so there was a distance. Same cross was seen at the cap of this pen. So we can see that there was a change in the distance between these two crosses. This test का नाम is called as Cober's test और ये बहुत ही यूजफुल है क्लिनिकली कोरिलेट करने के लिए इन ankylosing spondylitis. So these are the basic tests which we need to know. यहाँ पे if we ask the hip flexion, the L2 L3 nerve is involved. अगर knee extension करने पूछे patient को तो L3 L4 is involved. If we ask the patient to move the greater toe, to extend the greater toe, the L5 nerve is involved. And when we ask the patient to do ankle ka plantar flexion, the S1 nerve is involved. So what all special tests can we do for OPD? It is very important to correlate क्या होते हैं वो special test. Every clinical, every student, medical student, every intern, every PG scholars, every clinicians might have practiced this straight SLR test, also called as straight leg raise test, to check the sciatica nerve tension. As we can see, there is a doctor in the image, patient lying down on a supine position. एक leg उसका सीधा है and another leg is raised straight. कि कितना हो सकता है? Usually, if the range is less than 70 degree, then the patient is suffering from some grade of sciatica. But if the patient's leg, the tip of the toe is between 70 and 90, and if the patient is not having any pain at the buttocks, at the groins, at the lumbar region, then that patient can be called as SLR negative. See, as in the next image, we could see that there is a pain at the lumbar region. This is called as straight leg raise test. Another is Bragard's test. It is the same as that of SLR test. Difference इतना होता है कि SLR में हम लोग पूरा leg उठाते हैं. We don't ask the patient to move their ankle. The ankle is also straight. But in Bragard's test, we do the dorsiflexion of this ankle joint. As we can see in this video, leg completely raised है और जैसे ही plantar flexion किया उनका, so the patient was having pain. So this is called as Bragard's test, done to assess the L4, L5 and S1 levels of nerve. Next is slump test. Slump test कैसे करते हैं? The patient is asked to sit on the examination table. The leg is kept straight. The patient is asked to bend his cervical, thoracic and lumbar into flexion position, forward bending. After flexing, he needs to keep his arms, rotate his arms towards the backward side. And if the patient is having any kind of pain in the lumbar region, the slump test shows that there is some kind of neural tension at the lumbar region. And thus, the areas of pain with positive results. See, these are the three positions of rotation of hip joint. As you can see, the flexion, the abduction, and the external rotation. So, flexion का F, abduction का A और external rotation का ER. इसको हम बोलते हैं Faber's test. Faber's test में क्या करते थे? पेशेंट का पहला जो नी है वो पीछे फ्लेक्स किया. नेक्स्ट abduction मतलब पेशेंट का लेग बाहर किया फ्लेक्स करने के बाद. And then the hip joint is rotated, externally rotated, to see is there any tension, is there any pressure, is there any kind of pain, And if there is any kind of pain, you must suspect is some kind of sacroiliac joints, lumbar tension, femoral tension may be there. देखिए यहाँ पे एक patient, the patient is lying down and the another hip is kept like this way, and his knee to this ankle is kept on the another leg. It resembles four. यहाँ पे आप देख सकते हैं फोर का शेप बना हुआ है. So interpretation ये होता है कि and the doctor over here is pressing the patient's knee. On pressing the knee, if the patient is having any pain in the groin region, then there is some kind of hip pathology, hip joint pathology being seen. And if after doing this examination, if the patient is having any pain at the buttock region or at the posterior side, the pain may be elicited as sacroiliac joint, some kind of pain is there. इसको हम बोलते हैं फेबर्स टेस्ट. यूजुअली हम अपने ओपीडी में प्रैक्टिस करने के लिए वी मस्ट नो 4 to 5 टेस्ट रेगुलरली टू असेस ऑल द जॉइंट पेन्स. द फर्स्ट वन वाज द SLR test. The another one was Bragard's test. The third one is slump test. And the fourth one is Faber's test. Another test we'll go with this is femoral nerve stretch test. First, we'll play the video to understand. So, can you see this? The patient is in the prone position. The knee is been flexed by doctor, and there is hip extension. If there is any kind of pain, if there is any kind of stretch, I will again play the. Okay. So can you appreciate this yellow muscle being moved? जब हमने पेशेंट को नी फ्लेक्स किया तो कैन बी अप्रिशिएट दिस टेंशन इन द psoas मेजर मसल्स. ये टेंशन क्रिएट होने के बाद अगर इफ देयर इज एनी काइंड ऑफ पेन in those regions, so you can elicit that there is some kind of femoral nerve getting irritated in the localized region. This is a Gainslan's test in the sacroiliac joint. So this was nothing, just the patient's hip joint was rotated out externally and the patient was having a severe pain in the sacroiliac joint. So every test resembles everything. As you can see that in Gainslan's test, it is specifically for sacroiliac joints examination करने के लिए for OPD. The Faber's test is for hip joint, sacroiliac joint and lumbar spine. This is for L4, L5 and S1 nerve. Bragard's test is again usually done for L4, L5 or S1 nerve irritation. So we have completed at least 6 tests which is regularly practiced in OPD. It is very important for every clinician or future clinician to practice this. So what is the role of imaging in lumbosacral region? Why is it necessary? See, when a patient is coming to you with a low back pain, जब उसको कोई प्रॉब्लम है कमर में आता है, तो कब हमें इमेजिंग, कब हमें एक्सरे, एमआरआई, ब्लड टेस्ट कब लिखना चाहिए? So if there is any no red flags, if we are giving the patient the conservative management, and if the patient is responding well, so no need of any investigations for that thing. But if the pain is greater than 6 weeks, or if it is worsening, then a clinician must confirmly go for an X-ray or MRI. Now, next question: when to go for X-ray and when to go for MRI? X-ray के लिए तभी जाते हैं to check the bone alignment, if it is aligned properly or not. क्या उसका curvature बराबर है क्या? Is there any kind of fracture in the spine? क्या पेशेंट को स्पॉन्डाइलोस्थेसिस है क्या? If there is any degenerative changes, the doctor must go for an X-ray to find these things. It is more cheaper but not accurate. If we want accurate, uh, accuracy will be seen in MRI lumbosacral region, spine. In this, soft tissues can be appreciated very well. You can see the muscles, the tension in muscles, the atrophy in muscles. If there is any disc herniation, if there is any compression, nerve root compression, everything can be appreciated in MRI lumbosacral region. So it is very important कि कब हमें एक्सरे करना चाहिए एंड कब हमें एमआरआई करने चाहिए. If there is any nerve root tension, if there is cauda equina, this is an emergency condition which we discussed in the last class. And the last is it will give us a proper presentation of soft tissue pathology. But if the patient is not fit for clinic, if the patient is not giving results, if the red flags are present, अगर एनेस्थेशिया फील हो रहा है, ब्लैडर या बवल डिसफंक्शन ऑब्जर्व हो रहा है, ट्रॉमा का हिस्ट्री है, और न्यूरोलॉजिकल एग्जामिनेशन धीरे धीरे डेफिसिट होते जा रहा है, अंडरस्टैंड दैट इट इज अ रेड फ्लैग. स्पेशल कंडीशंस, जब हम पेशेंट में कोई कोई ऐसे पेशेंट्स होते हैं जिन्होंने अपने डेंटल इम्प्लांट किए हो. देयर आर सम पेशेंट्स हु हैव दिस पेसमेकर. some patients do have their metallic implants in their body, orthopedic implants. तो ऐसे पेशेंट तो एमआरआई नहीं कर सकते सर. So what will be the choice of investigation in that? So the choice of investigation will be this CT myelography. The patient with any kind of implants in their body, go with this CT myelography, which will tell you that there is any nerve root tension present or absent. It will give you a clear picture. So when to go for a dynamic X-ray? Normally X-ray, normal X-ray से dynamic X-ray में क्या difference है? See, many patients come to your OPD who are old aged, and usually these people do have this Parkinson's. They do tend to shiver a lot. They stable नहीं रह पाते. So when there is instability, go for a dynamic X-ray. And last but not the least, you can go for CT scan if only MRI is not possible, because it is very limited. It won't give you a soft tissue ka image that clearly. So it is better to go for an X-ray or MRI. So the key message is MRI is very good for neural and disc pathology. X-ray is very good for bone and alignment, and CT scan is for detailed bone assessment. So we have studied about the radiology. The most common clinical cases a clinician will encounter in his OPD will be a low back mechanical pain. A low back mechanical pain. Usually जो पुअर पोस्चर में बैठते हैं, जो यूजुअली डेस्क जॉब करते हैं, जो ज्यादा मोबाइल ऑपरेट करते हैं, जो ज्यादा हैवी लिफ्ट करते हैं, जैसे वर्कर्स हो गए, लेबर्स हो गए, जो रिपीटेटिव मूवमेंट्स करते हैं, फार्मर्स हो गए, वो ज्यादा मैकेनिकली वर्क करने की वजह से this spine, not exactly the spine, everything, the muscles, erector muscles, multifidus muscles, the intervertebral disc, everything gets wear and tear. जब ये wear and tear ज्यादा हो जाए, जब पेन पेशेंट को बहुत ज्यादा हो जाए, तो it is called as low back mechanical pain. Usually one of my junior practicing in a rural area, he was saying that in local areas people do practice do have a practice of using diclo plus dexa to relieve the pain. It will relieve pain for some time, but it won't give a permanent solution. So it is a very common practice in the rural area of giving these injections for low back pain. But we have to differ by doing a proper clinical examination, doing a proper clinical diagnosis, and thus a successful treatment. Another image is of an MRI. So there are 4 images A, B, C, and D. So first focusing on the image D, on the posterior side of the spinal cord. Can you appreciate this nerve compression? Can you see this blackish part? This is not present on the right side. This is present on the left side. Same cheese, we find this in the reporting. Reporting में it shows that L4, L5 level पे the posterior, the central and the left paracentral disc herniation है. This is an image of a 45-year-old male which is showing disc herniation. It is a very common clinical thing. So here there is a 3D image. How this is a white annulus fibrosis, right? ये hard fiber होता है intervertebral disc. उसके अंदर a soft nucleus pulposus रहता है. So when that nucleus pulposus gets out, when it comes out from the annulus fibrosis, as we can appreciate in this image, this nerve is getting compressed. Because of this lumbar disc herniation, there is a compression seen. So this is called as lumbar disc herniation associated with nerve compression, compressed nerve roots. And thus the patient will have this radiating pain to leg. Next image is of an MRI scan, lumbosacral LS spine. This is a coronal view. As we can see, in the left side of an image, we can see this, that there is a degenerative changes. See, these are the normal spine, right? Absolutely white in color. But these degenerative changes are grayish in color, not blackish. It is grayish in color. So these are the degenerative change. As you can see in this image, can you appreciate this osteoporosis in L3 vertebra? And there are multiple small osteophytes seen in spondylosis. So here we complete the compression fracture. Here we complete the osteoporosis. Here we complete the spondylosis. Next question, after reading all these things, mind में ये आना चाहिए कि दो तरह के वर्ड्स देखने मिलते हैं हमें रिपोर्ट्स में. एक है स्पॉन्डाइलोसिस, दूसरा है स्पॉन्डाइलिस्थेसिस. अब ये दोनों को क्लिनिकली कैसे कोरिलेट करें? Let's see. So before learning the difference, first you should know कि स्पॉन्डाइलिस्थेसिस क्या होता है. स्पॉन्डाइलिस्थेसिस मतलब जहां पे वन वर्टिब्रा स्लिप्स फॉरवर्ड ओवर द बिलो वर्टिब्रा. मतलब जब पेशेंट का वर्टिब्रा गेट्स स्लिप्स फॉरवर्ड, साथ में दिस इंटरवर्टेब्रल डिस्क आल्सो कम्स आउट. दिस कंडीशन इज कॉल्ड एज स्पॉन्डाइलिस्थेसिस. इसके ग्रेडिंग्स होते हैं, मेयर ग्रेडिंग सिस्टम है. वी डोंट नीड टू गो वेरी डीप इनटू दिस. हाँ, देयर इज grade 1, grade 2, grade 3, grade 4, grade 5 डिपेंडिंग अपॉन द परसेंटेज ऑफ स्लिपेज of this intervertebral disc. So these are the two images as you can appreciate. This is an X-ray showing spondylolisthesis. How? Let's see. Can you appreciate in the left side of an image? Can you appreciate this sacrum? Yes, absolutely. ये normal sacrum है. Can you appreciate this lumbar? Yes, this is also normal. But can you see this lumbosacral joint? It is not fused together. Lumbar portion आगे slip हुआ है. And the sacrum is slipped backwards. So due to this slippage, there is not proper continuation of the spine. This condition is called as spondylolisthesis. Another on the right side, there is an image of an MRI. Can we appreciate this? This is the sacrum and this is the lumbar. Lumbar is slipped forward and there is a black cavity over here. So this slippage is called as spondylolisthesis. This is ठीक है, हम लोग ने एक्सरे कराया, हमने एमआरआई कराया, तो हमको पता चला. How will we clinically differentiate between spondylosis and spondylolisthesis? First thing we need to know that spondylosis में there will be disc degeneration. As we can see in the image कि आप देख रहे हैं कि यहाँ पे intervertebral disc का degeneration होता है in the spondylosis. But in the spondylolisthesis, vertebra slip होता है, vertebral slippage. This is called as spondylolisthesis. Clinically, the most important question was how to differentiate clinically, right? So if the patient, as we can see in the lower part where I'm showing is the symptoms. अगर patient pain है, morning stiffness है, उसको पेन एग्रेवेट होता है एक्टिविटी करने के बाद किसी तरह का, तो उसको हम स्पॉन्डाइलोसिस बोल सकते हैं। बट इफ But if the patient is complaining of low back pain with radiating to legs, if there is any sciatica kind of pain, if the patient is having this pain on standing on itself या walk करते time भी, तो that condition can be जहाँ पे hamstring जैसा tightness जैसा लगे, that condition is called as spondylolisthesis. So this is a very good example where we can differentiate कि disc का अगर if there is any osteophytes, if there is any degeneration, it will be called as spondylosis, जहाँ पे पेशेंट को सिर्फ पेन और स्टिफनेस रहेगा। बट स्पॉन्डाइलोस्थेसिस में पेशेंट को रेडिएटिंग पेन रहेगा, हैमस्ट्रिंग्स स्टिफ हो जाएंगे और पेशेंट को खड़े रहते हुए या बैठने के बाद भी उसको पेन रहेगा। दैट इज कॉल्ड एज स्पॉन्डाइलोस्थेसिस। फेसेट जॉइंट सिंड्रोम, फेसेट जॉइंट सिंड्रोम इट इज अ वेरी कॉमन थिंग, बिटवीन टू वर्टिब्रास को जोड़ने वाला होता है वो फेसेट जॉइंट। इट इज कंसिस्ट ऑफ कैप्सूल, अंदर का साइनोवियल फ्लूइड, द लिगामेंट। इफ देयर इज वेयर एंड टेयर, इन्फ्लामेशन, जैसे कि हम दूसरे इमेज में देख सकते हैं, यहाँ पे कार्टिलेज भी नहीं है, साइनोवियल फ्लूइड भी नहीं है और कैप्सूल भी एकदम डीजेनरेटेड है, जिसके वजह से कैन यू अप्रिशिएट दिस, can you appreciate this nerve getting compressed because of this irritation? Now, it may be due to arthritis, it may be due to inflammation, it may be due to any kind of injury. So, another thing, the most common clinical case you'll see is sciatica. Sciatica is a thunderstorm kind of pain. Let me elaborate it for you. The patient will have pain suddenly, anytime. पेशेंट ये पेन हमेशा कैरी नहीं करता, इट कम्स लाइक अ थंडरस्टॉर्म, इट गोज लाइक अ थंडरस्टॉर्म, द पेशेंट नेवर नोज, इट इज नॉट अंडर द कंट्रोल. So how to know, how to tell that if a patient is having sciatica or not? Let's discuss this. The patient पहला बोलेगा that his knees feels wobbly, he is unable to walk because of pain, the patient is unable to do any activity. First primary complaint. Second complaint that the patient, the अभी तो जैसे कि patient is not able to walk and sit also, so how will the patient run? So he will be having a discomfort. Second point. Third point is like the patient is unable to trigger or reproduce the pain intentionally. इसका मतलब क्या होता है? The patient can't control his pain, even if he is having pain. Like if we are having cervical pain, so we'll move towards that side and we can assess कि हाँ मुझे यहाँ पे पेन है, मुझे वहां पे पेन है. But sciatica is not like that way. Sciatica pain comes anytime, it goes anytime. So it can't be produced by the patient himself. The fourth thing is that the patient will pass the sciatica test if you do proper clinical examination, where SLR is positive, Lassegas sign is positive, Taylor's test is positive. You can assess that the patient is having some kind of sciatica test positive. Last, it is not compulsory, but patient may frequently face this problem of urination, micturition, defecation. As we see, this genitofemoral nerve is also involved. The main focus of this image is, next he discusses about cauda equina. आप यहाँ पे देख सकते हैं लिखा हुआ है cauda equina. Yes, absolutely. This picture. Nothing much to read. Just read the term cauda equina. So this image is a pony braided tail of a horse. यहाँ पे इसको pony लगाया है. And if we unlock this pony, it becomes free like this way. So what it has to do with clinical examination, right? So I want to show you this. Can you see the hairs being splitted? Many hairs are there at horse. Same is cauda equina syndrome. Cauda matlab tail, equina matlab horse, and syndrome matlab a group of symptoms occurring. So let's appreciate in this photo. Can you appreciate this normal photo? Yes. So there are many roots of this nerve getting elaborated. But on the right hand side, there is a compression of nerve roots. कौड़ा इक्विना सिंड्रोम भी ऐसे ही होता है क्योंकि ये हॉर्स के टेल जैसे अपीयर होता है, इसीलिए इसको ये नाम दिया गया है कौड़ा इक्विना सिंड्रोम. इट लुक्स लाइक एन हॉर्स टेल अपीयरेंस. It is an emergency conditions and it is compressing the root nerve. So clinically, can you appreciate this? Where is the sacrum and where is the lumbar? Absolutely desiccated. Absolutely desiccated. So there is, but obviously, if there is any kind of desiccation between the intervertebral disc, desiccation between the two vertebrae, nerve roots are going to get compressed anyhow. यहाँ पे एमआरआई में वी कैन सी द स्पाइनल कॉर्ड इज गेटिंग कंप्लीटली कंप्रेस्ड. ये एक सर्जिकल इमरजेंसी है जहां पे द पेशेंट नीड्स टू अंडरगो एन एमआरआई एंड अर्जेंट सर्जिकल procedure like discectomy or many other procedures depending upon the condition of a patient. So this photo was put ki, see, being a MS Shalya Tantra, it is very important ki the S5, S4 और S3 के जो nerves है, it provides a sensory function to the rectum, perineum and inner thigh. So saddle anesthesia देने के लिए, so it is very important to know the anatomy of S3, S4 and S5. Very rare condition you will see in your OPDs is sacroiliitis. It may be cartilage खराब हो गया हो, synovial fluid कम हो या thick हो गया हो, atrophy हो गया हो, hypertrophy हो गया हो. It is very important. Joint space reduced. If there is any sclerosis, where in between the sacrum and the iliac joint is called as sacroiliitis. Ankylosing spondylitis is a very vast topic. We will not go very deep. I just want to show you the findings. यहाँ पे curved spine है, यहाँ पे straight spine है. There is a loss of normal curvature. Ankylosing spondylitis is also called as bamboo spine. It is very stiff like bamboo. Can you see in this image? एकदम एक के ऊपर एक है, straight like a bamboo vase. As we can see in this images, what is an ankylosing spondylitis? कट शॉर्ट करके बोलता हूँ, autoimmune है, inflammatory है, causing arthritis in the spine, in the sacroiliac joints, resulting in severe to chronic pain and stiffness in the patients. Bone marrow edema, what are the reasons for that? There may be edema in the bone marrow, there is some erosions, sclerosis, fat metaplasia, partial ankylosis. So this is an reactive arthritis. Let me cut short it for you because we are running short of time. Reactive arthritis मतलब क्या होता है? Let's focus on this point. यहाँ पे लिखा है gut food poisoning और genital infection STI. अगर आपके बॉडी में अन्य जगह पे इन्फेक्शन होने के कारण, if that infection gets traveled to your spine, it causes inflammatory arthritis and it is called as reactive arthritis because there is some kind of infection present in body somewhere else and disturbing your spine. This is called as reactive arthritis. Spinal infections, everyone knows this thing. We don't need to go. Normally in this picture, you should see the spinal cord, the nerves, but we can see the pus collection over here. So this is one of the spinal infections. Last but not the least, this is some kind of tumor, spinal tumor, compressing the spinal cord, very beautifully shown in the image. It is of three types. As first we'll go with this image. बीच में होता है medulla. ये green color का जो sheath है उसको हम कहते हैं dura mater. And this is the extradural space, violet color. So if the tumor is present within the medulla, it is called as intramedullary. Can you appreciate this image? Yes, it is intramedullary, inside the medulla. If the tumor is between medulla and dura mater, so हम क्या लिखेंगे? medulla के बाहर extramedullary, intradural. Extramedullary मतलब medulla के बाहर और dura mater के अंदर. And the last is in this violet space. It is called as extradural, extramedullary. यहाँ पे can you appreciate in this image? It is outside this green band. It is extradural, extramedullary tumor of a spine. अब ये इमेज में देखना चाहेंगे. Can you see this white proper spinal cord? पूरे spinal cord के बीच में there is a black mass visible, not black, grayish mass. It is intramedullary. Whereas over here, ये जो black वाला है, it is getting continued, but this tumor is at the whitish portion. Tumor is between the whitish portion, तो वो intradural, एक्स्ट्रा मेड्यूलरी है, और यहाँ पे द इमेज इज नॉट सो क्लियर, बट यू विल अप्रिशिएट अ एक्स्ट्रा ड्यूरल एंड एक्स्ट्रा मेड्यूलरी. Everyone might have heard about this spinal TB of spine. So this is an image of a multi-level tuberculosis of a spine identified by 18 fluorodeoxy guided PET या CT scan concomitant to urogenital tuberculosis. So let's focus on this. Can you appreciate this flare? एक reddish flare आ रहा है at the urogenital area. But also with this, can you say this कि L3 में भी flare आ रहा है, T11 में भी flare आ रहा है, T4, T7 में भी flare आ रहा है. So this flare is nothing but TB of spine, which has been seen in this FDG PET scan. So this is a case of spinal TB, and a cohort study was done on this. So with this, we complete our most of the clinical examinations. Today, I know it got a little bit lengthier. So the key takeaway will be proper clinical examination, sahi diagnosis, and appropriate investigations is successful treatment की असली की है. I would like to thank my guru, Dr. Mahesh Sanghvi sir, for giving me this opportunity. And sorry for delaying the topic for today. This is myself, Dr. Nikhil Gupta, and the session is open for questions. You can ask your questions over here. Nine.
The plain X-ray, CT scan, MRI. Can any role of USG in this, the muscle tap of the spine or anywhere?
So the role of USG, sonography is for soft tissue organs, as we say. It won't give a clear picture to us. It won't give a confirmed diagnosis. But yes, we can. It gives a good impression of Doppler if there is any compression of venous supply. It will give us a good guidance for that. Apart from this, we can go for a soft tissue like muscles, but we won't get in a major image because the probe is very short.
Yes.
So it doesn't gives us a complete picture. Where is the pathology?
So the message is that it's a localized. Am I clear?
Yes, sir. It is a localized imaging.
Right. So some of the people, they should choose this USG, but clinically it doesn't work properly. So that the exact is, the first is plain X-ray, then you can go for an MRI. This is the ideal one. But at the same time, you should have to find out some another causes is there or not, diabetes or something like that, and that you should have to be understand with this.
Thank you, sir, so much. We have a question by Dr. Rahul. एक पर्सन है जिसको chronic back pain है and he has a fear that he is not able to run, sleep on his back. सडन रिलीफ मिलता है, कभी वापस पेन आ जाता है. सो व्हाट विल बी द डायग्नोसिस एंड ट्रीटमेंट विद दिस कंप्लेंट्स?
See, as per the clinical your question, what we myself and Nikhil understand that it is anything pathology between L3, L4, and most probably L4, L5, and L5S1. Because this has been, the muscles and the nerves and the whole management is start from here. So if you don't have the patient, what is the age? What are the chronicity? What is this, how many years he is feeling? And if any investigation is there or not, and diabetes, like, any disease is there or not. These are the more questions for this diagnose and to understand the treatment. But if all this normal, what we prefer is to go for if it is a sham, then we go for the Agni Karma. If it is not, then we will go for an Avidya Karma. Sometimes you have to do Agni karma and vidya karma both. Would you like to add something?
Yes, regarding management point of view, I have this key depending upon patient's अवस्था है, निराम अवस्था है कि सर आम अवस्था है, निराम अवस्था है, तो क्या इंटरनल मेडिकेशन डालना है, क्या अग्नि कर्म करना है, कैसे विद्य कर्म करना है. All this management will be taken in our next lecture by Dr. Mahesh Sanghi sir himself. He will be sharing his clinical experience with us. कब कहाँ कैसे किस अवस्था में कैसे यूज करते हैं, कौन सा मेडिसिन यूज करते हैं, क्यों यूज करते हैं, क्या यूज नहीं करना चाहिए. Everyone knows what to use, but what not to use is specially told by sir, and he'll be sharing his clinical experiences. Thank you so much, Dr. Rahul, for this question. Any more questions from anyone? I guess everyone is running out of questions, sir.
Thank you very much.
Yes, sir. Thank you, everyone, for taking your time.
All of Rahul you always be with us, and it will be an excellent presentation by Nikhil, and he's very good, better than me in this type of work. I had never done this work before that. I just only the practice, and I'll do the practice. I understand, but difficult me to explain this way. So I must congratulate Nikhil has picked up well, and he has been, try to do the best for you. Thank you very much, Nikhil, and everybody who has been participate over here. Rahul, are you happy with this answer or not? You can unmute yourself and answer. You can have any video also.
Dr. Rahul,
You there?
are you okay with the answer? Okay, no problem.
Thank you very much.
Thank you so
अगले
much.
अगले फ्राइडे को मिलेंगे, जरूर मिलेंगे, और वो बहुत अच्छी तरह से जो मैं प्रैक्टिस करता हूँ और हमें यश मिलता है उसके बारे में बात करेंगे. थैंक यू वेरी मच. गॉड ब्लेस यू. गुड नाइट एवरीबॉडी.
Thank you so much, sir. I would like to conclude. Thank you so much, sir, for giving me this opportunity. It was a great knowledgeable thing to gain knowledge experience from you. So to conclude this, lumbar back pain evaluation in OPD requires a stepwise approach. Clinical examination पहले, followed by the need based radiology, ensuring precise and rational management. Thank you everyone for joining this session. The flyer will be shared in the group for this Friday's session. Looking forward. Thank you so much. Hari Om.